Good morning. My name is Basil Matta. I'm a consultant in anesthesia and critical care at Cambridge University Hospitals, and I am the Senior Medical Director for Massimo International. It gives me great pleasure to give you this lecture on why we need to monitor the brain, how to optimize sedation. Now, in anesthesia and critical care, we are very good at monitoring organs. We monitor the heart, the lungs, the kidneys, the liver, but the one organ we seem to forget about is the brain. Less than 5% of patients who are undergoing anesthesia or sedation in intensive cares worldwide have their brains being monitored. And it's surprising because our drugs and techniques work on the brain, and the brain is the most difficult organ to heal if injured, and we certainly can't replace it. And there is this thinking that if you get the hemodynamics right, that the brain is okay, but we know that's not the case. And we also know that really monitoring and protecting the brain is not just the job of those who work in neuroanesthesia and neurocritical care, it's the job of everyone that delivers care to patients. So why do we give an anesthetic or sedation? We want to be kind to our patients. We want them to be comfortable. We want them not to be distressed, and we certainly don't want them to be aware. Sometimes we give a general anesthetic or sedate patients because we want them to tolerate the endotracheal tube, allow us to ventilate them in a particular way. For example, prone, we want to use muscle relaxants. But we have to remember that actually anesthesia and sedations are not the treatment. It's what facilitates the treatment. And so they themselves cannot injure the patient. What's the common practice? The common practice we have is we look at what we deliver in terms of anesthetics and not where they are working. So we use MAC, which is a very poor indicator really of anesthetic depth. It just tells you that 50% of patients don't move when subjected to a surgical stimulus. TIVA is really a predicted plasma concentration, not what the concentration of that drug does at the site. So what we essentially do is monitor what we give, but we don't know exactly how much of that is getting to the brain at any time throughout the operation. And we know, as I already said, that hemodynamics parameters are not adequate enough to detect depth of sedation. Now, we know patients are worried about being aware during anesthesia, but really the recall of the surgical intervention is not the only important thing. We know now that, for example, delirium is a big issue. We know now that length of stay is a big issue. We know now that the use of vasopressors is a big issue. So we need to get the sedation right. And when we talk to people about depth of sedation, they imagine loads and loads of EEG signals coming at you, which are difficult to interpret if you're not an expert, which is why really many processed EEG, you take the raw EEG, you put it through a filter, you come out with a nice algorithm. We all like algorithm. We like numbers. We like linear scales. So 0 to 100 or 20 to 40, 25 to 50. But not all those things are equal. So, for example, I am very much in favor of using SETline, that patient state index. The PSI has been worked in more than just an algorithm that summarizes the EEG forms. We look at quantitative measures. We look at observer arousal. We look at suppression ratio. We look at lots of things to give you this linear scale that goes from 25 to 50, where 25 is really deeper anesthesia and 50 is towards a lighter anesthetic. Important signal acquisition is really, really critical to what you do for processed EEG, because the electrodes sit on the forehead and underneath them is muscle. So EMG activity will interfere with the signal you are getting unless you're obviously using needle electrodes. And that's why we worked very hard on our processes to make sure the interference from the EMG is as little as possible, and the PSI is a true reflection of as much as possible of the brain activity rather than the muscle underneath it. Now, despite all of this, if you have massive EMG activity like shivering, like moving, it will also affect the processed EEG. And sadly, as we get older, and we don't want to get older, power on our brains get less. And you can see from the slide here, red indicates high power on the DSA, blue indicates low power. As we get older, whether you're anesthetized with sevoflurane or propofol, your power in your brain less. What's the implication for that? The implication for that is that because all biological signals are signal to noise ratio, as the power in our brain reduces, the noise around it becomes more important. And sometimes you get this paradoxical increase in those parameters like BIS or PSI when you're deeply sedated and elderly, and you think that you need more anesthetic, but in fact you need less anesthetic. Let me show you what I mean. You have to work throughout the power spectrum of the EEG to get a true signal, especially in elderly patients. And this is what we have done with our generation 2.0 SedLine. We look throughout the power spectrum and get a better signal throughout the ages. But we have to remember that even with SedLine, and as good as it is, at very high anesthetic doses in very elderly patients, you may get this paradoxical increase, which is why a number alone is not enough. Now, if you want to use a PSI number, you want it to be stable. You can see here from this graph that it doesn't matter what type of anesthetic you use. PSI is pretty consistent. It gives you a reasonable measure of anesthetic depth throughout the period, throughout the types of anesthetic you are using. And I'm very pleased to say that the AAGB guideline, the Association of Anesthetists of Great Britain and Ireland, has updated the guidelines recently to include processed EEG as a recommendation. It should be used when TIVA and neuromuscular blockades are used, but also it should be considered not just during TIVA and muscle relaxants, but TIVA inhalation anesthetic, because it allows you to really reduce the dose of anesthetics you're giving and improve recovery. And what's really heartening about this is that you can see that the association now is talking about not relying on an index alone. We as specialists, we are anesthesiologists, intensivists, should have a better understanding of EEG waveforms and the way they're interpreted. And so that is really a real step forward as far as I'm concerned. Not surprisingly as well, you can see here that the American Association of Anesthesiologists, also in the recent publication Anesthesia News, shows that really the perception in the US is pretty similar. Minimum alveolar concentration is a simple population average of likelihood of movement to a surgical stimulus. It is not intended to be a surrogate of consciousness, although many anesthesiologists use it as that. And it shows you the importance that you really need to use the processed EEG more than just a number. And really, if you use the DSA, you can reduce the incidence of delirium and hypotension. You can have faster emergence. You can have confirmation of the intravenous hypnotic dose you are giving. And, you know, this is useful for all types of surgery, all types of ICU stays, and all ages. So it's really, again, really important step towards monitoring all patients undergoing anesthesia and sedation. Now, a number is not enough. What do we do? Well, the DSA, or the density spectral array, takes all of those waveforms, takes the power in those waveforms, and converts it into a beautiful color spectrum, as you can see here. You can see high power in red and low power in blue, and you can see the x-axis and the y-axis, one is representing the time and the other the frequency. And those two white lines you see running across, it's what's called the spectral edge frequency. That's the frequency below which 95% of the power is there. And what's really nice about those is that you can track those lines when the patients are going to sleep. They're normally wide apart, they come together, and then when the patient's waking up, they separate again. It gives you a real good indication of what's going on. Drugs have got a signature on the DSA. You can see here that propofol is a signature with the alpha activity around 12 hertz there in red. You can see that sevoflurane. Ketamine is an interesting drug because it produces activity around the 32, 33 hertz, which disturbs the PSI. So if you're using ketamine, a single number like PSI or BIS will not work because that will be affected by the dose of ketamine. So you have to look at the DSA and dexamethasone there. And other drugs such as benzodiazepine, used by gastroenterologists, used for sedation. What you really want a patient who is sedated or undergoing procedural sedation is to have an EEG that looks like that one on the left with a PSI 74, 75. They're still communicating it. When they get to that EEG signal you see on the right here, deep sedation, this is when they're unconscious, and that's not what you want them to be. So it gives you guidance on sedation as well. Dexamethasone has got the same. You can see the difference between a high dose and low dose if you're using dexamethasone for sedation. So the DSA is a really very, very useful tool, gives you all these things. But what else does it give you? So you can look at the most comprehensive brain function monitor available now, the SED line, and you can see that we give you the raw EEG signal. If you want to look at the raw EEG, the PSI, the patient state index, all the way trended throughout the procedure, and the DSA on the bottom. And what's really nice about the DSA is that you get to see burst suppression. So burst suppression is periods where the brain is activated and then stops, and activated and stops. And that's been associated with delirium, with increased length of stay, with mortality, with increased use of vasopressors. And you can see burst suppression on DSA by these black lines with blue tips. So you can look at it from the end of the bed and go, the patient is too deep, they're going into burst suppression. And the comprehensive monitor can be displayed in any way you like. You can alter the parameters. You can show the state, patient state index. You can show the suppression ratio. You can show the artifacts. You can show asymmetry between right and left. So it's a very, very comprehensive monitor, but you don't have to use all the parameters. You can eliminate some of them. You can see what you like, depending on your experience and depending on your need. Now, some people say to me, SED line sensors are bilateral. Do you have unilateral? The reason we use bilateral sensors is because it gives us a much better indication of what's going on in the brain. And some people, although it's not a Massimo recommendation, some people use it ingeniously. This is a paper from the Cleveland Clinic in Abu Dhabi, where they adapted the adaptation of the sensor. And you can see here that they can get the same quality signal from the sensor when placed infraorbital as opposed to on the forehead. And these guys have managed to use it in neurosurgery and in ophthalmology and in ENT with a very good successful effect. Now in ICU, people say, I don't need sedation measurement in ICU because I assess my patients clinically. And that's true. The RASS score is a very good agitation and sedation scale. In those patients, you can assess clinically. But in those patients that you cannot assess clinically because they've got stiff lungs, because they need deeper sedation, because they're requiring muscle relaxation, what do you use? That's about 30% of the patients in the ICU you cannot assess clinically. And I am very pleased to see that those patients are, when they're heavily oversedated, they really don't benefit from it. They get more delirium, they require more vasopressors. And it's really heartening to see that a group of experts, 25 experts, have looked at the ability to use processed EEG in critically ill patients and recommended that for those patients that are sedated, whether they're paralyzed or not, that cannot be clinically evaluated, depth of sedation monitoring would be very, very useful thing to do. And so we are seeing a lot of uptake and depth of sedation monitoring in the ICU for the reasons that 30% of those patients cannot be assessed clinically. Another thing that we see in ICU sometimes, especially in traumatic brain injury, is non-convulsive seizures. These are patients who are having seizures in the brain, but you don't see any physical signs of it in terms of jerky movement. In the ICU with traumatic brain injury, the incidence is around 20%. In general intensive care, the incidence approximates 8 to 10%, but it's very hard to detect. And what does that mean? Those patients have got higher ICPs, higher lactate pyruvate ratio, and worse outcome. And although the SED line was not designed as a seizure detection, you can see here by looking at these two screens, one on the left, one on the right. The one on the right shows you this spike activity in the EEG on the raw EEG. You can see the spike activity reflected in the DSA, and you can see that the PSI has gone up. And what that does is a trigger to say this patient needs a full EEG to determine whether they're having non-convulsive seizures or not. And interestingly enough, you know, oversedation is not just a business of the ICU and anesthesia. This is a paper looking at procedural sedation, of which really 50% of the patients were oversedated, had a PSI less than 50. And more importantly, about 25% of those patients had PSI less than 25, consistent with burst suppression. So these are patients coming in for procedural sedation, ending up being so deeply anesthetized that they get burst suppression. Does everyone that has an increased depth of anesthesia do worse? Of course not. But the evidence now is mounting. We know that the increased depth of sedation, increased depth of anesthesia will produce a higher incidence of delirium, higher incidence of postoperative cognitive dysfunction. Requirement for vasopressors increases. Requirements for longer days in the ICU increases. And complication increases. And even mortality increases. So really, the effort now is directed towards getting the right depth of anesthesia, not overdosing these patients with anesthesia. And I want to leave you, I only have 15 minutes, and I want to leave you with the thought that really the question should be, why wouldn't I monitor the brain in my patients? Not why would I monitor the brain? We're not asking people to drill holes in heads. We're not asking people to do fantastic maneuvers. We're asking you to effectively put a band-aid on the forehead that costs, you know, minimal amount of money compared to what the cost of anesthesia and surgery is. So really, there is no excuse now not to monitor the brain of the patients. And I think all patients undergoing anesthesia or intensification have their brains monitored. Because imagine if it was my brain, I would certainly want it to be monitored. And wouldn't it be a tragedy if you get a patient to recover from severe illness like multiple trauma, sepsis, or even COVID, only to find that we've given them a brain injury that's going to stay with them for the rest of their lives?